Neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Hello and good evening. It's been a hectic day thus far, and we're having a good time here in the studio. I'm Catherine Berg, and we're going to talk this evening about the dynamics of trauma surgery. We talk often about all kinds of different specialized surgery, but sometimes you don't know what's coming your way, and the doctor that we have with us this evening specializes in trauma surgery, and so we're going to get to that in just a few moments. If you have any questions during the program that you're interested in calling us for, it's a live program. It's 881-0013. You can also catch us on youtube.com. You can go to youtube.com and then search for El Paso Physician Live, and we're going to be airing there as well. We want to say a huge thank you to the El Paso County Medical Society, but also we have a student here today with the Paula L. Foster School of Medicine who is going to be manning our phones, and that is Emily Rick. And Emily Rick and I were joking back and forth. We had one doctor that we are missing, so I said, Emily, you're a medical student, you can come join us, but she chickened out, so she's hanging over there. But anyway, we're going to concentrate again on trauma surgery, the dynamics of what happens in that emergency room and surgically in that realm. Again, live questions, 881-0013. This is the 25th anniversary of the El Paso Physician, and a huge shout out to the El Paso County Medical Society for bringing this program to you. I'm Catherine Berg, and you're watching the El Paso Physician.
It's interesting because I'll have some of these doctors on the show, and yeah, they're doctors, but I've known them for 20 years. We've been doing this show for 20 years. You know, he talks about farts, and he talks about diarrhea, and he talks about all kinds of things that nobody wants to talk about. And that's what's great about this show, because you get to hear those things on the show and go, I'm not the only one. It's great. It's the El Paso Physician.
Trauma care, what does that mean? It's not something we ever want to be in, but every now and again there is a car crash that happens. There is someone that falls out of a tree when they're cutting branches. There's all kinds of things that go on. And we have a surgeon with us this evening, Dr. Grace Ng, who is going to be talking about some of the gruesome things that you've seen, but more importantly, how is it that you help put people back together at the end of the day? So I want to say thank you so much for being here. I know that we talked about your special being trauma surgery. You also said that you deal a lot in critical care and that you are an intensivist. And I just love that word because I know that we were joking a couple of months ago about there's hospitalists now and you're an intensivist. So along with trauma surgery, what is it that your specialty is? And I'd love for you to kind of define what intensivist is. It's hard to say that, intensivist.
Sure, absolutely. Thank you for having me today. So essentially, I'm trained in trauma surgery and surgical critical care. And as an intensivist, we work in an intensive care unit. And so there's medical intensive care units and there's surgical intensive care units. And so we specialize in patients that have surgical issues or that have traumatic issues.
Okay. And so to say traumatic injuries, I know it's a whole big book to say that, but what are the most common surgeries that you perform as a trauma surgeon?
So personally, as a trauma surgeon, a lot of what we do involves getting into the abdomen or the chest. Those are our major, most people that have injuries oftentimes have injuries to the abdomen or the chest, and we even do sometimes the neck. Or any kind of traumatic injury could be any part of your body. So it could be your head, which would require a neurosurgeon. It could be your bones, which would require an orthopedic surgeon. So we're a multifaceted team that work together with numerous surgeons for us to be able to give the best care to our patients that are injured.
And that's nicely explained. I know that originally we were looking at neurosurgeon and orthopedic surgeon and then the trauma surgeon. And I said, of everyone to be able to be here today, the trauma surgeon's the one. So thank you for that. Because, and I'm kind of glad that we don't have gruesome pictures, because every now and again we'll see something and it's like, okay, I need to fix that. So your realm, orthopedics is fixing something mechanical. I get it, right? And then when we're looking at abdomen, that's really life-threatening stuff. So when you get into that situation, and let's throw out an idea of a car crash. And often there's injury to the chest. You know, I'm thinking steering wheel, and this is something where just think of some case studies that you've worked on before and traumas that we might be able to discuss here. what might happen in a car crash? And I'm thinking person sitting, steering wheel's here. In the old days, the stick shift was a thing. There's not that thing anymore so much. Eyeglasses, airbags, etc. So kind of take it from that front and tell us some of the things that you've seen and you've had to work on.
Sure, absolutely. So, in trauma care, everything is unexpected. So in any part of your body can be injured. So if we just take a car crash, for example, if we go the neurosurgical route, they can have a head injury. If they hit their head really hard on the steering wheel in a window, or if they get ejected from the car, they can have a head bleed, and it could be severe and it could be life-threatening. And then we can just kind of march down the body. You can have a neck injury from a seat belt. Seat belts can also cause injury to intra-abdominal organs. If the impact is hard enough, you can get rib fractures, which could also then damage your lung and bruise your lung. If we think about the abdomen as a general, we have lots of things in our abdomen, and those injuries can be either very straightforward to deal with, or they can be fairly complex if multiple organs intra-abdominally are injured. So that could be your liver, your gallbladder, your spleen, your pancreas, your intestines. So anything on the inside.
Thinks about the spleen,
yeah,
right?
but it's actually one of the most commonly injured organs back there. It kind of hangs out here on the left-hand side. And so, then we keep marching down, your bladder, and then you go to all of your bones, and really anything can be a life-threatening injury because you can bleed from it. So bleeding is number one reason why trauma patients are so sick is because if you lose your blood, you're not providing oxygen, nutrients to the rest of your body. So the first thing that happens when someone comes in that we have to be acutely aware of is how good is their blood pressure.
Right.
So
on that note too, if you're, when you said seatbelt and ribs, I'd like to kind of go to that section for a little bit. And the airbags, that's face, I get it, that's cranial surgery, then you're looking at those kind of bones. But when there's a rib or two broken, and I'm just thinking too, you've got stuff, you've got the stomach, you've got the lungs, you've got everything kind of in the way. Are there two surgeons that would have to go in and operate if there were ribs broken, had to get them out of the way, then go into the soft tissues? Is that something you do completely? Do you have a team? How would that work if there's multiple injuries happening in the chest area? Because there are some bones involved.
Sure, of course.
But just in general, how would that work out?
Yeah, so it depends on the injury, of course. So a lot of rib fractures end up being non-operative, meaning they don't require any kind of intervention, and it's time. Bones will heal. The concern that we have with rib fractures is how displaced they are, so how, angulated they are, because you're supposed to have a smooth bone. And when you break it, it of course causes some kind of trauma, extra trauma because of that. So trauma surgeons actually can do rib plating as part of their skill set.
Tell me what that means, rib plating.
Sure.
Just saying that.
So that's like our inset into some kind of orthopedic trauma because it's the bone.
But we're covering it today. There's
bone,
been disclaimers that we've thrown out there, and we're doing the best that we can with orthopedics too. But it's very fascinating because I feel like that's something that it's almost like puzzling things back together, right?
Yeah, so we essentially realign the ribs so that they become more normal in ability. So, there's a lot of anatomy and physiology to how we breathe. And so your ribs have to expand for you to take a deep breath in. So your chest cavity expands and your bones kind of help you do that. And so when your bones are broken, every time you breathe, it causes a lot of pain. And so pain control is one of the biggest issues with people that have multiple rib fractures because your bones are misaligned. And so just like any broken bone, you would like to be able to realign them if it is the right thing to do at that time. So not every rib fracture requires plating or realignment. Some of them will just heal on their own. But in that scenario, we do that as trauma surgeons. And then inside of the chest cavity, so for example, if there's a lung injury or something like that, we also can take care of that. Anything more centralized, we would have to, again, it's a multidisciplinary team, so we'll bring in our cardiothoracic surgeons if necessary, our vascular surgeons as necessary as well. So.
And all of that, so I'm always fascinated with the different disciplines and on the operating table and the amount of time, because we talk a lot about time in different medical procedures on this program. So we've got the orthopedic surgeon, he's getting the bone stuff out of the way, you're getting all the abdominal stuff, and now we have issues with the heart. Do you literally just move out of the way? The cardiologist then comes in and does his stuff, or how does that approach work? And I know everything's different and every situation's different, but I'm just trying to think of the different doctors that are operating at any given time.
Sure, so it all depends, and as you said, it depends on the situation. So we have to treat the most life-threatening thing first. So if it means that they have a cardiac injury, then that's the first thing that we address. And that could be us in conjunction with the cardiothoracic surgeons. We take care of that first. Things that require immediate, that do not allow us to pump blood to the rest of our bodies and provide the oxygen and the blood and the nutrients that we need to heal and to stay alive, really, is what we go to first. So we control bleeding, we address anything that is life-threatening, number one, and then everything else subsequently comes into play.
Okay, that makes sense. So let's get away from car accidents for a little bit. And in your tenure in doing things, is there a certain surgery that sticks out to you in your mind that you thought, okay, this is bad, and you get in there and there's a way to fix it? Is there something specific that you've had to deal with, just during your career that you thought, okay, I'm not sure how this is going to work out, and it worked out fine? Or, sometimes on the opposite side too, but just a storytelling type of a thing.
Well, there's many scenarios. I probably can think of a few, actually, and they're kind of generally, when people have polytrauma, meaning they have many different injuries from the same accident, you kind of, the most satisfying, like I said, is you go in, you see that there's blood in their abdomen, and you're like, we got to go in and figure out. Because you don't always know.
You have to search it. You have to
search
find
for
what's
it.
happening.
So
okay.
You get a gunshot wound to the abdomen, and your patient doesn't have a good blood pressure, so you have to go to the operating room and address it. You go in there, you look for it, you find it. You either fix the hole in the small intestine or the large intestine, you reconnect it, or you take it out, put it back together, stop what's bleeding, and then you close the patient and you're done. You
make this sound like it's like a mechanic. like you're in there, it's like I take this tube, I take that tube, and I'm just thinking to myself all the things that are going on in there. And as a surgeon too, we had a program a couple of weeks ago on robotic surgery, and as a trauma surgeon, there are so many things that the robotic surgery does with just tiny little clasps and what have you. Do you ever get to use a system like that? Are you hands-on all the time? And again, it's trauma, so it's fast. It's not like I've got weeks and weeks to plan this out. They come into the emergency room and boom. What are some of the procedures that you're able to use?
So usually we're kind of maximally invasive in trauma surgery just because there is no time, and you need to get in. So a generalized abdominal injury, we do an exploratory laparotomy, so they get like a midline incision right here in the middle. They just get cut down the middle.
Okay.
So we have the best visualization, because if you can't see, you can't do what you need to do. So that's always number one. Depending on the stability of the patient, that can actually kind of determine if we can do some of the more like laparoscopic or robotic surgery. That's kind of coming into play sort of in the background, but it's coming into the forefront, and in certain places and in the right patient, there's a possibility to use the robot to be able to repair some injuries. And the example that I can give is someone who's a stable patient that might have a diaphragm injury. And our diaphragms are fairly high, and so sometimes if you do open surgery, it's actually harder to get up there. And with a robot, you're able to actually have a fairly good visualization and be able to repair it.
So I'm going to ask, and I feel like I didn't prepare you for this, but when you're talking about a diaphragm injury in the robot, if you can explain, as you said, visually our hands and looking in there, but if you've got the robot and the cameras, if you can maybe explain to the audience how it is that the robot can see and how you're operating the robot so that you can get into, little crannies, was it crooks and crannies, as they say?
Sure.
That you couldn't do with your hands.
So you can get in there with your hands. It's more of a visualization. So usually, so we can see our diaphragms from our abdomen. So so just like laparoscopic robotic surgery in the abdomen, you utilize insufflation, so gas, to be able to insufflate, to open up the abdomen, and that's how we do all of our other surgeries. Like if we take a gallbladder out or appendix out, it's the same concept, except now we're focusing up here. So you can look at it as if you're putting in ports in your abdomen, you blow it up, and you put a camera in, and you just look up.
You're
looking up at your diaphragm, and you're able to see it. And then in that manner, that's how we visualize an injury and then potentially put the other ports in place so that it's in the right spot for us to be able to repair it.
So on any given, I have a question here from the audience, and I think we talked a little bit about it, but Sergio is listening and he's asking, do they immediately check for internal bleeding in trauma scenarios? And I think that you kind of mentioned that too. And what I'd like to do is think of somebody that's coming into the ER, and what tools are you using immediately to visualize what's happening? There's CAT scans, there's MRIs, there's this and that and the other. And again, feel free to throw out any case that you've seen in the past. Like who would get a CAT scan, who would get an MRI, who can you just clinically look at them and say, oh, this is what's happening, we need to fix A, B, and C?
Sure, of course. So it's interesting that you bring up A, B, and C. So we follow, trauma surgeons across the country and the world follow what we call ATLS, which is Advanced Trauma Life Support. And this is essentially a nation/worldwide curriculum that every trauma surgeon, every provider that does any kind of emergency care takes, and it's A, B, C, D, E. And that tells you, so we go airway, which is A, breathing, and then circulation, disability, which is how we tell about someone's neurologic status, and exposure, that's essentially us being able to remove all clothing and anything covering the body so that we could visualize any other injuries that could be covered by clothes, by blankets, and things of that nature. So there's a system. There's a system in place, and that's priority. So if you can't breathe, you're not alive. So we can't even take care of you. So we have to deal with that first. And then breathing kind of goes right along with it. If you have some life-threatening chest injuries that need to be addressed immediately, then we have to take care of that. The circulation means blood pressure. So let's talk about bleeding, right? So there are scenarios where a patient does not have a blood pressure, and if, say, for example, they had a gunshot wound to the chest and they don't have a blood pressure, we would immediately likely have to do what we call a emergency department thoracotomy. It's a resuscitative thoracotomy.
Okay, slow down. Thoracotomy in and of itself sounds interesting. So what is that?
So what that is you actually have to open the chest to be able to access the aorta, which is the big blood vessel that supplies our entire body, and be able to...
when you say open the chest, go in opening the ribs as well?
Correct. Okay. We get into the chest to be able to access the heart. We'll be able to see it, and it's doing like internal chest compressions. So usually when someone, what we say, if someone dies and they need CPR, we do CPR from the outside. So we press on their ribs to try and restart their heart by essentially helping the heart pump. So in that scenario, if, say, for example, your patient is near dying, you have to open the chest and you actually do internal compressions, which means you actually have the heart in your hands and you pump the heart to try to bring blood flow to the rest of the body.
That sounds so stressful. So as you're doing blood flow with your hands, is there a certain point where you just feel the heart coming back, and then you, like, how do you know when to let the heart go? That sounds so dramatic. But you're in there and you're feeling it. Is there a certain amount of beats that you would wait before you backed off? I'm just trying to think about how one would do that.
It's essentially you have to kind of observe and look. So what you need, right? So we said that the one thing that the number one reason why people don't have a blood pressure when they come in is they're probably bleeding. So your heart is empty. It doesn't have blood to pump to the rest of the body. So you feel that as you pump the heart. You know when it starts to get full and you're getting stuff out, and then you'll see it. You'll be able to, you can feel it and you can see it. It's right in front of you. So any small amount of time that you get away from that heart, you take a look at it, and you hope that there is a normal rhythm of the heartbeat that's going, and then there's other algorithms that we do thereafter to go what's next.
So I'm thinking too, a lot of blood is being lost, and this is where, maybe this is a shout out to anybody that needs to, if you need a volunteer thing to do, go give some blood, because trauma surgeons need it.
Yes,
so
absolutely.
when they're looking at losing blood, like you said, circulation's not going well, and so when is the introduction of blood come in? I know these are all specific to the case. So I'm just trying to get stories and ideas of verbalizing it to where we can create pictures in people's minds.
Of course.
So now we're bringing in a couple of, is it a liter at a time blood that you're giving in, or how does a unit, I know it's called a unit, but how
Sure.
much is a unit?
Yeah, so there's blood comes in components. So we have whole blood. This kind of gets into two different kind of topics. But yes, please donate blood.
Please donate blood.
We
Yeah, there you go.
do need it, and all of our patients are definitely. They don't know it, but you are saving their lives at that moment in time. So it actually makes an extreme difference in their lives. So at UMC, thankfully, we actually have whole blood, which was instituted within this past year. And usually when we think about blood transfusions, we think about transfusing what we call in components. So we would give PRBCs, which are just the RBCs, the red blood cells. And then you get your FFP, which is fresh frozen plasma.
Wow, look at this, okay.
Platelets.
Right.
And so together combined, those make up what our blood is as a whole. So in history, it's kind of come back and forth of whether or not we use each component on its own, or we just give you back everything that you lost. So because when we lose blood, when we bleed it as one whole. Like we don't bleed it out in little components.
Right.
So the military has actually been fairly instrumental in kind of bringing this back, and they've always used it. Actually, the military has walking whole blood units within those that are in the military. But this has kind of come back into civilian care, and so. Within this year that we've been able to transfuse whole blood. So whole blood units are about 500 milliliters of a unit.
Okay.
The PRBCs are usually about 250 each. So when we think about blood transfusion, if we know that the patient is severely injured and we know that they're bleeding, our first go-to is to give it back.
So I'm embarrassed that I don't know this, of all these times we've talked about blood. So you said going back and forth. Let's say we're in 1940 something and there's people that are in war, et cetera. Was it always whole blood at that point? Because there may not have been the process of separating. When did it become an idea of separating into components? I didn't know that it was separated into components. I didn't realize. I know that there's, plasma donation, et cetera, but for the general thought process in my head, I always thought it's always whole blood unless there's a different reason for it not to be whole blood. So what you're saying, if I'm understanding it correctly, is that usually it's components, but we're trying to get back to the idea of whole blood?
Yes, that is correct.
Okay, so when would that have been a thing? Like when would you just do red blood cells versus the whole blood? And maybe you can look at, decade ago, 3 decades ago, maybe just to kind of explain that process for people who are interested in the history of that. I had no idea.
Sure. I can't tell you the exact
Oh no,
dates
just kind of
when-
around,
when it was,
just kind of curious.
I believe that it's like I think it's around in some of the World War II, and is sort of when it was a little bit more well discussed and thought, but not out. I think it was not outright what they did in the hospital systems. It was more so within wartime. Because if you think about if you have to separate blood, it requires machines and things of that nature, which you can't have on the field,
That's
right?
what I'm
In the
thinking.
military,
That's far more
you can't
complicated
have
to separate it.
So, the nice part about getting it as a whole is exactly the thought process of you don't lose it separated. You lose it as a complete whole, and there's many advantages to the utilization of whole blood. There's less anticoagulants in it, right? So if you're storing blood, blood clots, right? Or we hope that it does. It would be normal if your blood would clot. And so if you're storing blood, you have to have anticoagulants in the blood itself. So when you're giving it back, you're also giving back some anticoagulant just by sheer nature of it being a preserved unit.
Okay.
And so with a unit of whole blood, since you're essentially you get more blood in the RBCs in that package with less of the anticoagulant in it. So it's actually more beneficial in terms of that, because every traumatic patient that comes in, they are already at risk of having coagulopathy, which means that you're more prone to bleed because you've injured some part of your body. And that's just our body's natural reaction to being injured. So.
That's fascinating. I didn't realize that. And so here goes, I guess a follow-up question to that is, if there's multiple injuries, but when I say injuries, flesh wounds that you're bleeding out from. So then there's where the magic comes in, right? We have to make sure that breathing's open. We got to get that going. Can't do anything without oxygen. Blood is flowing, and you're also trying to stop the blood. So tourniquets, et cetera, et cetera, et cetera. When someone, and I'm going to go to EMS, let's say. So now there's been a big accident, and EMS starts something. We were talking a couple of weeks ago about these mobile hospital rooms, and that's kind of what it is. Taking yourself out of being the trauma surgeon for a moment and maybe put yourself in the headspace of an EMT, and they have a bad accident and there's a lot of bleeding going on, and they have to stop the bleeding before getting to you so that you can actually work on them.
Sure.
What is it that they're doing in the ambulance? And again, I'm just throwing it out there with whatever scenario you want to throw in there, but something that's, you know, internal bleeding, external bleeding, et cetera. How are they handling all of that?
Sure. You know, we can't do our job without EMS.
Right.
And so, you know, major shout out to all our EMS crews that come to us. And, you know, depending on which EMS crew we have, so some of the flight crews have a little bit more resources on their helicopters than maybe just a ground EMS does. But all of them, of course, so in terms of stopping bleeding, let's just say, for example, someone has a big cut to their arm. We always advocate pressure first.
Right.
Just put direct pressure on it, whether it's you see it and you just put a finger on it, or if you put some gauze on it and you just do direct pressure. Tourniquets, as we know, is something that has definitely come back into play and has required extra training, because there are appropriate times to place a tourniquet, and sometimes it can do more damage than good. But in the setting of being out in the field, you have to deal with what you're given. And so if it means that that's the best way for them to stop the bleeding, then we just have to be very judicious when the patient arrives for us to be able to remove the tourniquet as soon as possible, because, you know, when you put a tourniquet on, you're stopping bleeding, which means you're also stopping blood flow to that part of the body, which could cause damage. It could cause nerve damage, it can cause muscular damage. And so these are kind of things that when you're in the moment, you have to use the resources that you're given. And so there's a Stop the Bleed campaign that is nationwide, and it's advocated by the American College of Surgeons and the Committee on Trauma. And essentially, you know, it's a stepwise thing, right? It's how we can save a life potentially if you're know, and you're in a scenario.
I love this, Dr. Ng. So I'm going to ask you. We're all now on a field trip, and Dr. Ng is here to teach us how to stop the bleed. I love that. So if we could maybe go into how you would help lay people who are camping or who happen to be, you know, on a running course or whatever, I would love for you to kind of go through that for our audience so they can kind of understand how that works too. I want to understand it. I felt like I took, you know, life-saving and lifeguarding, all that kind of stuff, but that was like 35 years ago, you know, so what's new?
Well, I mean, believe it or not, there's nothing extremely advanced about it. It's very basic. The whole point of is direct pressure is the best way to start. So if
and don't be afraid to jump in.
Yeah.
I think that's one of them too, right? Just don't be afraid to jump in.
Because, you know, anyone out there could end up helping to save someone's life. So if someone is bleeding out from an arm, and obviously the person who's injured is not going to be thinking about how they can help themselves, because they may not be able to at that time.
Right.
So as a bystander, you know, if you see something bleeding, the first thing is, if there's one thing that's bleeding, you put your finger on it and just kind of hold. Hopefully you have something that you can, you know, guard yourself to be safe. So this is another thing, is you also have to remember to keep yourself safe. So you never know what someone else's blood has. But, you know, so you still have to be able to protect yourself. If you have a gauze or some kind of cloth or something of that nature, then you can, you know, make a dressing of sorts to maybe kind of fold it up kind of like a handkerchief and be able to place it on whatever is bleeding and hold pressure. You know, anybody has a tendency, if they see bleeding, you know, to just start, you know, everybody kind of goes a little nuts, and that's a normal reaction. That's not it's not a criticism. It's just, this is how people react. This is being a human being. And so, you know, you kind of have to take a breath and then
Yeah,
and then
step
kind of
back a little
step back
bit,
into for
right.
just like a second,
Right.
and be able to kind of think about it that way. You know, obviously schools should usually have little tourniquet packets that are part of this campaign, and essentially, you know, you place, if you need to, and you absolutely can't stop the bleeding, you place that tourniquet on there, and you mark what time that actually was placed, because that's what's essential. What is essential is how long have you actually cut that blood supply off. And so that's usually like the last resort. If you absolutely need to and you cannot get control any other way, then you do need to do that to hopefully not let somebody bleed out. People kind of talk about makeshift tourniquets if they don't have like an official one. And sometimes people come into our trauma bay with belts or sheets tied across whatever extremity that has been injured. And you know, certainly, as I said, you know, people do what they have available.
Exactly.
And so for us, we have to take tourniquets with a grain of salt, because we do know that they are potentially life-saving, but that they also can cause some injury. But as anyone out there is, you know, start with pressure. Start with direct pressure. And then, you know, if you think about something that's bleeding here, you might want to hold above and below it, just to get control.
Right.
Above
nice
and
to say.
below, put pressure above and below, and that should be able to help you tampen out, or, you know, stop or slow down the bleeding until somebody until EMS comes and they can take the patient.
You know, I was sitting here thinking, and it just seems so intuitive to us, like, we'll call 911. But every now and again, in the heat of the moment, and everything's just going crazy, luckily we all have our phones, for the most part, on us all the time.
Yes.
And so I'd say the most important thing, and tell me too, what stories you've heard or what you direct patients to do, or I guess again with the training. When do you stop to call 911? I mean, I'm thinking to myself, I've got a hand here, I've got a tourniquet here. Oh shoot, my phone's 20 feet away. But that's the most important thing, is you need to get help here.
Right.
Right. So maybe talk about was it the Stop the Bleed campaign? What steps are in there, and when do you call? I mean, immediately if you can.
Immediately if you can,
Okay.
and then you just do what you can until somebody that is fully trained can come and help you. You know, hopefully there's always somebody else available that can grab your phone or whatnot. If if the injured person is awake enough, perhaps they can help you.
Right,
If it's one
exactly.
injured, you know, if they have, hopefully it's just one extremity that's injured, maybe they have the other one that they can help you out with. Or if you've held pressure for a little bit and it's controlled and the patient who's injured is awake and can talk with you, then, you know, you can try and work together to try and call. But that's always a tough situation, that despite the fact that we have so much access to being able to communicate with people, that potentially in the time that it matters the most,
Right.
it may not be right next to you.
Exactly.
So,
And I'm thinking too, with accidents and trauma, I mean, usually, obviously things like that happen in our home, but I'd imagine a good amount of time we're out in public or some kind of public, so not be shy and just
Right.
scream for help.
Yeah.
Because there is some, and again, you're thinking about intuitively, once you get out of that shock system of trying to go to it. So this is kind of an educational area this evening here too. I have a question here from the audience. I'm not quite sure this really goes along with what we're talking about so much, but I want to respect the question. And for a disclaimer, we do the best that we can with the questions that we have. It's
Sure.
usually a sentence or two.
Of course.
But Barbara asks that she had a fracture on the bottom of her pelvis, and how long does that usually take to heal? What physical therapy would help heal it? And I know that you are, a trauma surgeon, but fracture pelvis, I know that we were talking about this being an orthopedic show originally as well. So to the best of your ability,
sure.
because you were talking too about everything in the abdomen, the pelvis is kind of in the bottom, and pelvic fractures are pretty common in accidents.
Yes.
So take that and answer it any way you'd like to, but also we can go back to the idea of when a pelvis is fractured and you've got the stomach, you've got intestines, you have all the bladder, everything's going on in there. Again, how do you navigate that in the operating room?
Sure. It depends on the actual injury. So, you know, there are injuries that don't require any surgery at all, and the orthopedic surgeons will take a look at the scans and they'll say, you don't need to do anything about, or we don't need to do anything about this. They go to physical therapy, try to walk on it, and if they're fine, then they kind of then they move on. And you know, bones take weeks to heal as a general whole, no matter where it is. Some bones take longer, or they're harder to heal, or they hurt more, depending on where they are. But so in a setting that a pelvic fracture does not require operative intervention, it's mostly physical therapy and just pain control to help the patient be able to kind of get back to as normal as they can. If in the more severe cases of pelvic trauma, those can cause a lot of bleeding, and so that can then turn into a couple of facets. If the trauma is severe enough, the orthopedic surgeons can do a temporary fixation, which keeps the bones in alignment, because anytime any broken bone rubs against bone, it bleeds some more. So in some of these severe cases, the orthopedic surgeons can come in and they place an external fixator, and it helps to keep it in place until more definitive operations can be done once the patient is more stable. So yeah, it is all right in here, and it can be a challenge. And sometimes we do run into each other depending on when the case is done, whether we go do our part first and then they do their part later. And so it's kind of a, you know, it's a discussion, it's a teamwork of sorts. You know, Dr. Adler, who we work with very closely with one of our orthopedic surgeons, you know, he's called us in where he says, hey, you know, I'm like close to your incision, you know, so we work together very well, and we just talk to each other. It's a big team effort. Trauma care is multidisciplinary to its core, and it's not. And we talk about the glamorous things of being a trauma surgeon, and it's not necessarily glamorous, but that's what people think of the most. They're like, oh, this is cool. But trauma care is
totally what I said to you when you walked in here, isn't it? I was like, hey, nice to meet you.
It's so much more than that, right? We require the nurses that take care of the patients at bedside, the physical therapists, the occupational therapists, our speech therapists, our physiatrists, our everybody that gets involved in the care is really important for any trauma patient to be able to actually recover from whatever accident or injury that they've had.
So I'm going to ask about the toys that are laying around, the emergency room, in the operating room, like you were talking about this internal fixator, right? Is that just something that's hanging on the wall? It's like, you know what, we need pelvic's broken here, we just have to get the fixator. What is it that you have at the ready at any ER? And I'm just, in my head, I'm thinking, is there a closet full of stuff that you might need? And I know everything's got to be sanitized and perfect, but just in general, and this is where hospitalists come in, and this is where other crew members come in, so to speak. How is an ER operating room set up in comparison to other general surgeries?
So the operating room is the same.
Okay.
So when patients first come in, they come into our trauma bay. And the trauma bays have what we call Pyxis, and within the Pyxis there are myriad of supplies that we need to take care of our patients.
A myriad of supplies,
and
I like that.
It's the most essential things that we need to be able to care for a patient right in the ER. So we have, like, our thoracotomy sets are in there. We have, lines for big IVs and gauze and tape and all kinds of things. We have ultrasound machines that help us. You kind of mentioned this at the beginning of, like, what do you have to help you assess bleeding, internal bleeding as well. So we have ultrasound machines that are right outside our trauma bays that our emergency physician colleagues that also play a huge part in trauma care with us. They come in and they actually do an ultrasound to be able to check the lungs, they check the heart, and they check the abdomen for any overt signs of bleeding. And that's something that is extremely helpful and is a huge adjunct to assist us in sometimes diagnosing and sometimes in performing procedures. So we have all of those within the ER. And then if the patient requires an operation, we proceed to our operating room. And in the operating room, of course, all of our supplies that we need are there. And they are in multiple closets, I guess you
Right.
can say.
Right.
Secured and
Yeah.
sterilized
Right.
is what, and then we call for what we need, and it's
Well, Dr.
usually-
Ng, you are carrying this entire program on your shoulders right now. I am super impressed with you because I'm throwing all these things your way, and I kind of don't want to throw the neuro stuff your way. I don't want to throw the ortho stuff your way because I don't think that's fair. But at the same time, you were talking about really, you know, the myriad of things, but also the myriad of doctors. And you threw out some of the disciplines earlier, but I'd like for you to maybe describe what some of the disciplinaries are. I mean, orthopedics, I think, is self-explanatory. Cardiologists obviously is. Emergency room physicians. I mean, that in and of itself is kind of like the trauma surgeon, right? It's like, what all does that encompass?
Sure.
Have fun with that question. I know it's huge, right? It just goes all over the place.
Yeah. Well, but that's medicine, right?
Yeah.
We kind of have to. We help each other out. We can't be we can't be each other without each other. So, our emergency department physicians are kind of they're the frontline people in the hospital. You know, if someone shows up in the ER, they're the first ones that they see. Everybody else gets called in after the fact.
Right.
Except for in the setting of a trauma, we all show up together. So. The ER physicians, they in our trauma bay, they help us with airway. So this is usually sort of how we create our team when we take care of trauma patients. And so they actually stand at the head of the bed in case there is an airway issue. If a patient requires intubation, so if they need a breathing tube because they can't breathe, they actually are the ones that take care of that for us in every single trauma that we do. And then they help us with the FAST exam, which is utilizing the ultrasound to be able to help identify other injuries as needed. And so they are the front lines, and then we get called and they tell us, hey, this patient needs to stay. And so, you know, it's a big teamwork of people. We're orthopedic surgeons, we know they do the bones, neurosurgeons, they take care of the head and the spine.
And the spine,
Yeah.
see, that's right, the brain and neck. Okay, yeah.
Brain, neck, and back.
Yeah,
so
good
they,
point.
they go all the way. So, and we have a lot of head trauma here, and so we are very grateful for our neurosurgeons. We talked about our cardiothoracic surgeons that help us with the heart and the chest. Our vascular surgeons that help us deal with.
I'd love to talk a little
Yeah.
bit about vascular surgeons
Sure.
because I'm thinking with all this trauma, I know that we were talking about abdomen, but now we're looking at not necessarily orthopedics because that's bones, but then you also have nerves that get damaged. You have muscles, you have veins and arteries that are messed up. So that too, when you're talking about blood flow, boom, that seems like airway, fine, blood flow now. Vascular surgeons, kind of describe what they do. I mean, I know it's
Sure.
big and it's all over the body, but in the world of trauma.
Yeah, so they're essential. So if they have, you know, we can kind of go through a couple of things. So if we think about the big blood vessel, the aorta in our bodies, when that is injured, we need
Watch out.
We need them,
Right.
and they have different abilities. So there's open surgery and there's endovascular surgery, which is more minimally invasive. And so previously, you know, again, as time has evolved, more technology has allowed us to be able to provide more interventions that are not as invasive, right? So we think of open surgery, right? Big incisions and things like that. And some things do require that. So for example, if the femoral artery, which is the artery here in your groin, gets severed, that needs to be repaired. And so we call in our colleagues and they come in and help repair that, and you restore the blood flow to the rest of the leg. If there's an injury to the aorta, sometimes it requires an open surgery. Sometimes they can fix it via endovascular techniques, meaning it's minimally invasive. They poke the groin in to get catheters and stents up into the aorta, and a patient's life is saved from not requiring a very big surgery. There was a big surgery, but not a big incision. And so some of these advances that we've had over the past several years have actually been extremely beneficial to all populations across the board.
So I love how you transition that, because that would be a natural transition question, are advances. And I know we talked a little bit about our friends at, you know, all the EMS folks. Just in general though, because I'm thinking also somebody severed an artery, like, let's say aorta issue, and they're coming to the hospital, but it's going to be a while before they get there. Let's say half an hour. With this training, again, we're talking about stopping the bleeding, and I'm going to be morbid when I ask this question, but how long would it take someone if there was no one to help, and the aorta is severed? Bleeding out is a horrible way of saying it, but I don't know how else to say that. But if there was no help, how long would the body be able to? And I know different situations.
Not very long.
Okay.
If it truly is severed, that's almost death.
It's almost immediate because it just.
Yeah.
Okay. I'm getting a couple of questions here from the audience. Actually, I'm going to let that one be for a little bit. I would like to talk a little bit about trauma surgery, but in adults versus children.
Okay.
And I know this is not pediatrics, I get that, but I know with orthopedics, there's the growth plate and there's, injuries that you kind of have to pay attention to because until you're 18, you've got growth plates that still kind of move around and what have you. But in your experience, the type of traumas that, and let's say kids prior to the age of like 16, what type of trauma injuries do they usually have, or what are some of the most common? I think with adults, it's, car crashes. That for some reason, that's where my head goes. But kids, bicycles, motorbikes, or et cetera,
So in our region, ATVs are fairly common, and we get fairly severe injuries from ATV accidents. And that's not new to most people, but this is something that within our region has been quite, it causes quite a few injuries here. And in kids, in very young children, what we are always most concerned about that we don't really like to talk about because it's not a pleasant thing to discuss sometimes, but in these younger children, it's the non-accidental trauma, meaning the child abuse cases. And so,
it's good to bring them to the forefront, though. This is the place to do that. So let's talk about that.
Sure.
Yeah.
And those are the toughest cases, right? Because you're with one of the most vulnerable populations of patients that you're dealing with. These kids don't really have a voice. And so when they come in and they are severely injured, or even if they have one injury that causes suspicion for us, it's important for any provider that sees this or has any kind of suspicion that they need to start working up this patient to make sure that they don't have any other injuries on top of it. And sometimes it could be a fracture in their femur, and that's hard to do sometimes. Kids are very pliable. They, they're kind of like basketball in a way. They're not.
Right.
They're not
No, I get it though.
but
Yeah.
their skeletons are a lot more flexible than an adult skeleton is, and so their injuries are a little bit different. So we can talk about that they have more internal injuries, potentially without any outward signs of injury. So they could maybe have a head bleed without a skull fracture. They could have a chest injury, like a lung injury, lung bruising, without any rib fractures.
Interesting. Right.
And so, with children, we have a high level of suspicion when we see them, just to make sure that they are being cared for as best as they need to be and can be. And so that's something that we advocate fairly heavily for. And within our region, it's now become it's under the border rack, which covers all of this region.
Oh, the border rack, that's a good one to talk about too. Yes.
They have been instrumental in ensuring that we are advocating for and making sure that we're educating any provider and ERs to, if there is a suspicion, send them to a trauma center so that we can completely work up the child and get everything that's necessary to care for them.
It's interesting you talk about border rack. I feel like we did a show with them years ago, and I was fascinated with everything that border rack does. I don't remember what rack stands for. Regional. Do you remember what border rack? Regional. Bottom line is, so I'd like to give them a plug because without that extra arm for trauma in general, we'd be in a less better place. Can you explain a little bit what border rack does?
Yeah. So essentially, these racks are everywhere in the state, and essentially, so ours, of course, is confined to our region,
right?
And it essentially helps unify the system. So you review everything, the injuries that you see within your region that are special to your region, and you essentially try to unify care, right? So if we all do things differently, there's going to be too much variability. And granted, there's always going to be variability in how we care for patients, but there's also a standard of care that comes across all healthcare. So one of the purposes of Border Act, because there are many, is to be able to help unify that. And they've done a lot of work with the non-accidental traumas to ensure that we know, what are the red flags? What should we look out for? If we have a suspicion, send them to a level 1 trauma center, or a level 1 or 2 trauma center that can actually take care of these injuries. So.
And a Border Rack, so you said, and I'm not familiar with others other than ours, how and when, and you don't have to give it a year, but when did the emergency system realize that this might be a good thing to do? Like, who may have come up with that? Because I think of firefighters are involved, emergency techs are involved, you've got city involved, county judge involved, mayor involved, in emergency response systems. And I say that, I know we learned a lot during the August 3rd, because that was a massive amount of people at one given time. But with Border Rack, how is it that they are in communication with the team, the response team, and again, going anywhere from county to city to all the different emergency folks?
So they have representatives from every hospital and the counties that are all participating within it. And there's monthly meetings, subcommittee meetings, so there's committees and then there's subcommittees. And so each one is focused on certain aspects of healthcare within the region. So it's not just specific to trauma, they do a lot of work with stroke and things of that nature. And so the monthly meetings, that are the generalized meetings, and then the subcommittee meetings are what kind of bring it back together. Everything comes back to the general meeting to ensure that everybody is doing as unified of care, delivery of care as we possibly can, so that everyone in this region can get the best health care that they can have.
I love that. I remember when we did that program, and it was the Emergency Preparedness Program. And I want to say that after 9/11, and we all feel like that's so long ago now, but it really isn't that long ago, that there was the idea of, okay, there's a big thing happening right now. What does everybody do? And I just remember being impressed with how our border region has it together. So just a shout out there. Another question, actually, I'd like to focus a little bit on children here again for a bit, because I'm thinking about brain injuries, and I know you're not a neurosurgeon, but I am fascinated with what happens to the head when the head gets, ATV accident in general, with adults versus children, because again, there's, excuse me, the bone is a lot softer and pliable, like you said. Excuse me. Even though you're not a neurosurgeon, what are the kind of things that are in play there?
Sure. So one of the first things is, of course, we identify the injury, and that's either, usually via imaging. And once we find the injury, then we have to define the extent of the injury. And so some of them have a little bruise in their brain, and they're just a little toggled. They have a concussion, but they're still talking to you, and they're doing everything that they should do. And then they can go home, hopefully in the next couple of days or so. Others, they may blossom over time. Some of these bleeds get worse, and that could be across the board for children or adults. And then, if it's severe enough, then they require surgery, and the neurosurgeons will also then come into play there and how and when they decide to operate on a child or an adult.
Or an adult, yeah. So how does one know, for example, somebody comes in and you said blossom over time. So what would be the tools that are used to see how that happens? Are they doing several MRIs? How long do you keep them? I know every situation's different, but in general, we're thinking, okay, this might be one that we foresee blossoming over time. And I know that's kind of like a game time decision. I respect that. How does how does the team of doctors kind of think, okay, this is one we need to look at, we think that one can go home, and why?
Yeah, so again, it depends on how you present, right? So if it's, usually even if it's a small one, we will observe these patients overnight. And they usually end up in the intensive care unit. And they go there because somebody can check them almost every hour to make sure that they're still doing what they're supposed to. So we check them neurologically to make sure that everything is equal, their eyes are equal, their pupils are equal, they can talk normal, they're able to move both sides the same. And so it's very close monitoring. And then usually, depending on the bleed, likely they'll get a different imaging the next day, a repeat imaging. So that could be a CT scan, which we use more so in the adults. In the children population, because radiation does have a chance for causing cancer, depending on the head injury, they may get an MRI to be able to evaluate whether or not it is worsened or it's stable. And then the neurosurgeons review it, and then we move on from there.
And you move on from there. Goodness, we're about ready to wrap up the program. What I'd like to do is, I know you've been just fired questions the entire night, and again, you are a trooper and a half. Is there anything that we haven't covered that you'd like to talk about really quick before we wrap up? I feel like I've asked you way too many questions.
Okay.
You're such a trooper, like I said. But in general, and I'm just thinking maybe for audience at home, concussions, you mentioned that, what to look out for, when to bring someone to the ER, when do they call 911? Maybe that's a good one to throw out there.
Sure. And it's, if you're able to watch someone fairly closely at home, then that's something that you could stay at home and, but if there's ever any question, go see a physician or go to the ER. You never know. And that's the hard part about any kind of traumatic injury is that you may think that something is very small and it could end up being something more severe. So, it's hard to, again, it's a case-by-case basis, but if there is ever any question, definitely talk to some kind of a qualified healthcare provider.
And I know that you're with UMC, and UMC is very kindly underwriting this program this evening, but in general, 911 and whatever the closest, when we're talking about trauma, whatever the closest places around you would be a good thing to do. I feel like I don't have time to ask another question, but at the same time, we have I do want to actually ask this, and we were talking about neurosurgeons. I only have one more minute. For the neurosurgeons, I'm not going to ask that because it will go into a whole nother thing. I will do this. Emily Rick, I don't know if we're able to put the camera on Emily, but Emily also has been a trooper this evening. Hi, and we did not put you on camera. I feel like I should make you come on over. But Emily is there, and she is the one that's been taking our calls this evening and bringing your questions over my way, which is really nice. And I want to say extra thank you to Dr. Grace Ng, who's been here and really did a great job tonight. UMC, thank you for underwriting. And again, a huge shout out to the El Paso the El Paso County Medical Society, because they are the ones that really put this together and have been putting this together for 25 years. It's not an easy job to get all these doctors here, and sometimes doctors' schedules are crazy, which is what we're witnessing here tonight. So appreciate you being here. I'm
Thank you for
Catherine
having
Berg,
me.
and you've been watching the El Paso Physician.